Hello, my name is Arnav Agarwal, and I'm a third-year internal medicine resident at the University of Toronto. It is my pleasure to present the findings of our GEMINI retrospective cohort study addressing variation in the use of antibiotics for exacerbations of chronic obstructive pulmonary disease and association with clinical outcomes. The use of antibiotics in COPD exacerbations with radiographic evidence of pneumonia is considered standard of care. The benefit of antibiotics in patients hospitalized with COPD exacerbations is uncertain when there is no clear evidence of pneumonia. We therefore evaluated physician-level practice variation in antibiotic prescribing in patients hospitalized with COPD exacerbations and associated differences in clinical outcomes. We conducted a multi-center study of all patients admitted to general internal medicine wards with severe COPD exacerbations at 7 Canadian academic hospitals between April 2010 and October 2017, using the GEMINI database. We assigned admissions to admitting physicians and categorized physicians with 20 or more admissions into tertiles based on the proportion of COPD admissions with an active antibiotic prescription at 24 hours from time of admission. We compared variation in antibiotic prescribing and differences in inpatient mortality, hospital length of stay, intensive care unit transfer, and 30-day readmission to hospital. We also designed a natural language processing algorithm to identify patients with no radiographic evidence of pneumonia on X-ray and examine antibiotic use and outcomes in the subset. Regression models were used to assess whether associations between physician tertile of antibiotic prescribing and clinical outcomes were significant after adjustment for baseline characteristics. Overall, there were 6,426 eligible admissions for COPD exacerbation and 1,759 with no radiographic evidence of pneumonia. In the overall cohort, an absolute difference of 17.4% was seen in the proportion of patients receiving antibiotics across physician prescribing tertiles. In the no radiographic pneumonia subset, the absolute difference was 23.1%. Inpatient mortality occurred in 3.8% of admissions. ICU transfers in 2.6%, and 30-day readmission in 15.4%. Median hospital length of stay was 4.3 days. In the overall cohort, a small but statistically significant difference was noted in inpatient mortality across physician tertiles in unadjusted analyses. This difference was not significant after multivariate adjustment. A small but significant difference was also noted in hospital length of stay after multivariate adjustment. There were no significant differences in other outcomes across physician tertiles before or after multivariate adjustment in either cohort. To conclude, our findings show that antibiotic prescribing for patients hospitalized with COPD exacerbations varies substantially across physicians, unrelated to measured patient factors. Increased antibiotic use was not consistently associated with better patient outcomes. Thank you.